Hello, everyone, and welcome back to our series, Person-Centred Care in Practice. My name is Anna Flynn, and I'm the Director of Partnering with Consumers at the Australian Commission on Safety and Quality in Healthcare. And I'm delighted to be bringing you today's presentation from Disability Identification to Inclusion. But before I do, I'd like to pay respect to the Gadigal people as the traditional custodians of country where the Commission's office is located. I also extend that respect to all Aboriginal and Torres Strait Islander people and their deep time connections to land, water and sky. At the Commission, we recognise that knowledge about healthy country, community and culture has been developed by Aboriginal and Torres Strait Islander people over tens of thousands of years and has been shared for generations. We are committed to partnering with and learning from Aboriginal and Torres Strait Islander people through the work that we do. So before we get into today's webinar, I wanted to draw your attention to the Commission's new website, which has a clinical topic hub for intellectual disability and inclusive healthcare. Here, you'll find information to support health professionals engage with patients in a way that prioritises their individual needs and treats them with dignity and respect. These resources include accessible versions of the Australian Charter of Healthcare Rights, a standards user guide for the healthcare of people with intellectual disability, 4 steps to inclusive healthcare, fact sheets on good communication and positive behaviour support, and easy read documents on a range of different topics. You can find these resources by accessing the link above or visiting the Commission's website and viewing the clinical topics menu. Also, a quick reminder about our Person-Centred Care Resource Hub, where you can find all things person-centred care, including recordings of past webinars, case studies, newsletters, and information about our Person-Centred Care network, which has grown to over 6,000 members nationwide. And finally, I'd like to invite you to participate in our public consultation on the next edition of the National Safety and Quality Health Service Standards. We'll be releasing a draft for feedback on the 20th of July, and in there, you'll see a much stronger focus on person-centred care. So we'd love to hear your thoughts. So please sign up to the Engagement Hub on our website for updates and how to provide your feedback, and I'll put the link in the chat. So without further ado, I'd like to introduce you to our presenters and panellists today. Joanne Rowe, Project Lead for the Victorian Disability Identifier Project, will talk us through how the project was developed and implemented. I'll then be joined by Bradley O'Brien and Amy Miles, who have both participated in the Disability Identifier Project as consumers. I'll also be joined by Kath Feely, Louise Mogg and Kirsten Morris, who have implemented the project at different hospitals across Victoria. So, over to you, Jo.
Thank you so much for the introduction. Today we are speaking to you about implementing a patient self-report disability identifier into electronic medical record systems from identification to inclusion. As you can see from this slide, it is a multi-organisation, multi-research group collaboration. So I would just like to acknowledge our wonderful partners, the Parkville Precinct Hospitals, so the Royal Children's Hospital, the Royal Women's Hospital, Royal Melbourne Hospital and Peter MacCallum Cancer Centre, Austin Health, the University of Melbourne Disability and Health Unit in Population Health, Healthy Trajectories Child and Youth Disability Research Hub, and the Centre for Health Analytics. Also to acknowledge the traditional owners of the land and pay respects to elders past, present and emerging. And I'm presenting to you from the Wurundjeri lands of the Kulin Nation. So in 2021, the Victorian Department of Health established the statewide Disability Liaison program implemented across tertiary health services as part of the COVID pandemic preparedness and response. And this has really evolved over time and become an integral part of the Victorian health system. One thing that we really struggled with early on when embedding the DLO program across our health services was a lack of data available on patients with disability within our health services to inform us where to direct our efforts, and no process available for routinely identifying patients with disability that may be experiencing barriers to access. We know that people with disability face significant barriers to accessing healthcare, and that this contributes to poorer outcomes compounding across their lifetime, beginning in childhood. We know that people with disability are more likely to experience and prematurely die from non-communicable diseases like cardiovascular disease, cancer, mental illness, as well as communicable diseases. And we know that 1 in 3 Australians with disability need assistance to access healthcare. And failing to provide this assistance results in missed appointments, inaccessible communication and poor follow-up, avoidable ED or emergency department presentations and admissions, and adverse outcomes like code grey incidents and diagnostic overshadowing, which we know is an enormous issue. Despite this being the case, Australian health services have not routinely identified patients with disability in their intake or admission processes until recently. And this has really impeded our ability to provide the right support at the right time. So this was the driver for this initiative, to create something that could be used locally, but also recognising the broader gap, something that could inform the health system. Okay, so in response to this, in 2022, we undertook a co-design process driven by the DLO, the Disability Liaison teams partnering across the Parkville precinct hospitals. And this involved a rapid review and convening a technical advisory group. And in addition to embedding disability and disability data expertise at its centre, the project engaged consumers with disability and carers of patients with disability as subject matter experts, using design workshops as well as advisory roles. And this was right from early co-design through to the evaluation. And the participatory process involved iterative design workshops, so there were 6 in total, eventually arriving at endorsement of the disability identifier questions. We were very fortunate at this point to establish a partnership with Austin Health, who were also doing work in this space. And this provided us with a unique opportunity to look at how the DI worked not only in very diverse health services, but also in different health information and electronic medical record or EMR systems. So with Parkville Precinct hospitals operating on a shared system called Epic, and Austin Health with Cerner. And the DI went live in the respective EMR systems in March 2023, and we were then able to complete a large-scale evaluation starting in November of that first implementation year. And we'll dive a little bit deeper into EMR system smarts and implementation in our panel discussion. But this overarching approach was very much health service embedded and driven partnering with health service consumers. So the framework really allows ongoing learning and improvement. Disability identifier approach closely linked with its real-world application. So the early co-design and later optimizations based on the evaluation resulted in a patient self-report methodology comprised of 3 questions that take on average 5 minutes to complete. So the question 1 is our primary identification question, and this was designed to conceptually align with the International Classification of Functioning and the operational definition of disability in Australia's National Survey on Disability, Ageing and Carers, with the SDAC, which is our gold standard for disability identification in the population. And question 1 also incorporates a definition of daily activities, and these encompass all of the ICF activities and participation domains, including self-care, domestic life, education, social and community life. Our question 2 is intended to capture information about the area of difficulty experienced And these areas can be mapped to the disability groups used for reporting from the SDAC, so sensory and speech, intellectual learning, physical, psychosocial and other, noting that the areas of difficulty included in the DI questions may tend to focus on function rather than medical or diagnostic groupings. There is an option, however, for patients or their carer to add information on a condition or conditions related to their areas of difficulty, should they wish to do so. And our question 3 is intended to identify if there is a need for assistance or adjustments to access healthcare services. So question 3 can be directly linked to a referral pathway or additional questions about the type of adjustments that are required. So this slide shows how the DI can work in practice. And this is an example from the EPIC EMR system. So here the patient or carer can complete the questions directly themselves in the patient portal, or the clinician asks the patient or their carer the questions and then enters the responses directly into EMR. The responses are then immediately and very prominently displayed in the patient's record, and this allows clinicians to easily view the patient's responses and then ensure that reasonable adjustments are considered in subsequent patient care and healthcare encounters. We can also generate EMR reports for routine patient screening to identify patients that are needing assistance, as well as reporting for other analytics that helps us to better understand our patient population. And this is an example of how the information can be displayed in the patient's record. And again, this is what it looks like in EPIC. So clinicians can hover over that international symbol of access, which is our disability flag in the patient's record, and see a snapshot of the patient's responses. There can also be further integration. So, for example, here it can pull in the NDIS key contact if the patient has also provided that information and consented to that being included. So the evaluation component of the initiative adopted a mixed methods study design, and this was guided by the theoretical framework of acceptability, which really helped us to look at the multifaceted nature of acceptability across multiple domains, including effective attitude, burden, ethicality, intervention coherence, opportunity cost, perceived effectiveness, and self-efficacy. As part of the evaluation, we conducted retrospective audit of over 20,000 DI responses in EMR that were collected within that first 9 months of implementation. We conducted an online survey with patients, carers and clinicians. We completed clinician focus group discussions and also patient and carer semi-structured interviews. Okay, so when used, the disability identifier questions demonstrated substantial utility in identifying individuals with disability and capturing relevant data about their difficulties and their needs for assistance when accessing healthcare. And at the time of the evaluation, so within that first 9 months of implementation, approximately 20,000 individuals completed the disability identifier. And as of June this year, we've had over 120,000 patients complete the DI questions across the 5 participating hospitals. When all settings were considered together, the prevalence of self-reported disability among the DI respondents was 18%. And interestingly, this has remained consistent across the life of the project. As you would expect, we did see variation in prevalence across age groups and specific patient cohorts. So, for example, we saw higher prevalence in settings that were providing disability-specific services. So important to keep that in mind when interpreting the data across the different settings. The reach and adoption of the DI varied across sites, with higher completion rates observed in settings where the DI was integrated into routine nursing admission workflows. So we observed this within the Royal Women's Hospital maternity stream, where they complete the DI in that initial maternity service booking appointment. And we also saw this at Austin Health, where they actually implemented the disability identifier as a required documentation or a mandatory question within their nursing inpatient admission workflow. And that resulted in completion rates reaching 95% of inpatient admissions at Austin Health in November of that first implementation year. We also found patients identifying as having a disability had nearly 3 times the odds of completing the questions in the patient portal compared to those without a disability. And this really highlights the potential of digital health platforms, and in particular patient portals, to facilitate that self-reporting and enhance engagement of patients with disability within our health services, providing we ensure that those platforms are accessible. So our quantitative findings in the TFA survey revealed strong general acceptability scores, and this slide shows all clinicians surveyed, as well as the total patient and carer cohort surveyed. But when we zoom in on a smaller subgroup, so this slide shows respondents who positively identified as having a disability and indicated a need for assistance to access healthcare. We found higher acceptability overall, and this is really our priority group, target group. Our qualitative findings provided us with further insights into strengths and challenges, and we've just included some quotes related to our key themes. We had clinicians participating in focus group discussions, indicating they felt the DI enhanced awareness and understanding of patient perspectives on disability, and in turn that it can provide a common language for patient and carer interactions to help identify what reasonable adjustments may improve experiences of care. We also saw concerns raised that some clinicians may lack confidence or willingness to ask the questions, and the importance of providing sufficient training and support to increase that confidence, as well as feedback on their experience completing the DI with different patient groups. So, for example, patients primarily experiencing fatigue or pain. Clinicians also highlighted the importance of integration of the DI into clinical workflows, and really addressing concerns around time and effort required to complete the DI, particularly in those busy clinical settings. But clinicians also noted that the DI itself may in fact contribute to decreased future administrative burden on both clinicians and patients if integrated and used appropriately. Patients and carers were optimistic that the DI would help enhance disability awareness and clinician understanding of required supports. There was also some concerns raised by patients and carers that the information provided may not be consistently used by staff due to things like heavy workloads and insufficient capacity or resources to provide those reasonable adjustments. Even so, there was hope that the DI itself would lead to better resourcing over time and contribute to improved patient and carer experiences. And in fact, patients and carers provided some examples of where the DI was already contributing to improved disability responsive care. So There have been some key resources that have been developed. These are available online and we can circulate these to the network. So the first one is the evaluation report that presents our findings from the mixed methods research in greater detail. If you are interested and keen to take a deeper dive, I would definitely recommend having a look at this report. We've also subsequently published a paper in BMC Health Services research, and this focuses a bit more on the acceptability component of the research. It's also worth a look at that. And last but not least is the Accessible Care Toolkit. This is provided as a companion resource for putting into practice the recommendations that are presented in that evaluation report. So the toolkit provides key considerations for adopting the disability identifier at a service level. It provides clinician guidance on implementing the DI questions, so how and when to ask the questions. It also works through some frequently asked questions that are based on the themes that arose out of the research that we did. And very importantly, guidance on how the information collected should be used. So for informing reasonable adjustments with clinical scenarios and examples, referral for patient support with some general resources included, and reporting and analytics that are possible with the data that's been collected. The Victorian Government are also soon to release a summary guidance on best practice in this space. So I just want to finish on a quote from one of our patient participants. It is so important for the hospital to be asking these questions to understand what patients with a disability, especially invisible disabilities, need. The challenge is then making sure the hospital can support our needs. Asking is the first step and hopefully helps to better understand the issues we face. And that brings us to the end. Please do reach out if you would like to know more. But I will now hand over to our wonderful panel for some questions. Thank you.
Thank you to Joanne Rowe for that excellent presentation showing us how disability identifiers can be used to support person-centred care and how important it is to see the patient as a whole person in order to provide high quality care. So welcome everybody to our live Q&A session. I'd like to introduce you to our panelists today. You've already met Joanne Rowe, but I'm also joined by Amy Miles, who is the consumer representative for Royal Children's Hospital, Bradley O'Brien, who is a community engagement officer for the Royal Melbourne Hospital, Kat Feely, Parkville's Chief Allied Health Information Officer, Louise Mogg, occupational therapist and disability liaison officer from Royal Melbourne Hospital, and Kristen Morris from the Disability Liaison Officer of Community of Practice, Senior Coordinator and Austin Health Disability Lead. Okay, welcome panelists. We've got some questions for you here. So I'm going to go first of all to Bradley. Bradley, we've spoken today about the systems and the implementation. But ultimately, this work's about providing healthcare experiences for people with disability. As someone with lived experience, can you tell us why it's important for health services to be asking about disability and support needs?
Thanks, Anna. Yes, each person's disabilities, as we know, is unique to themselves. Some people have visual disabilities, other people have hidden disabilities. Myself, I have a visual disability. I have a spinal cord injury, and it has resulted in paraplegia and other chronic medical issues. The next person who has the same type of disability as myself may have different disabilities or different needs and requirements. So by asking us about our disability, health services gain a greater understanding in how our disability affects us in our daily lives, in our own words, rather than in clinical terms. It's important as it enables us to have a greater say in our care. It also helps health services to understand our support needs and to have the supports in place whilst in hospital, such as clinical supports, occupational and physiotherapists, as well as the medical supports, as well as equipment and equipment availability such as hoists and commodes, as well as ensuring that all supports are in place upon discharge from hospital to also make us feel safe when we get home from hospital as well. So yeah, so that's basically, yeah.
Thanks, Bradley. And can you tell me, have you experienced this process? Is it something that you've gone through and it's changed your experience from previous visits to hospital?
Yes, having filled out the information in the disability identifier, it has greatly improved my hospital stays. They know that if I'm coming in, they know that I need a hoist. They know that I need a commode chair for transport to the bathroom. And they have the occupational and physiotherapists coming to visit me while I'm in hospital to make sure that I don't actually deteriorate backwards than what I've already achieved so far from being outside of the hospital setting. Because I find once I'm in the hospital setting, my condition can deteriorate quite rapidly in terms of functionality and things like that from what it was prior to coming into hospital. And that's due to a number of reasons. It's due to either being severely ill and just losing weakness, becoming weaker and things like that. So having all those facilities in place makes it a lot more helpful. And and I don't have to repeat myself time and time again of what I actually need. It's there waiting for me and things like that.
That's great, and it must be so much more reassuring to know that that's going to be the experience.
So much so, Anna. Yeah, it's 100% a lot better. I mean, it's still a scary experience for people with disability coming to hospitals because of the way things have been in the past. But with the disability identifier, it is actually my opinion is that actually is improving the way supports and that are being offered to people with disability.
That's great. Thanks, Bradley. Amy, you're a parent of a child with disability. I imagine that you've become very used to advocating for your child's needs. How do you think this collection of information can improve your experience and that of other families?
So, like you said, I'm a parent of a child with severe disabilities of autism and a lot of other things going on. Advocating has become part of my everyday life. It's often, I have to explain all my child's needs, repeating the same information to different healthcare providers, making sure that they've got reasonable adjustments so we can access care safely and comfortably. The disability identifier should be treated like any other information that they want to collect when we present to this, like allergies, Aboriginal Torres Strait Islander. It's really, really essential information that helps the healthcare staff understand our needs from the very beginning. Routinely, if it's not identified, the services can't predict early, can't plan supports, give us our reasonable adjustments. And in my experience, we've had severe problems arise because that hasn't been asked. It's not about labelling my son or our family. It's just improving the safety for us, for the care that we're going to, reducing that preventable harm, ensuring that we've got access to equitable care. For example, one of our biggest barriers that we face with families with disabilities, it's often invisible. Unless you've lived it, you don't really can understand it. And then when something goes wrong, when you present, that's when usually You get a lot of things moving very quickly, but that is not a great experience. They don't recognise, the communication we need. My son's sensory sensitivity is what he requires, behaviour triggers, and especially the support for not just my son, but for the family, my other son, my husband. We often need that extra support. We often are put in difficult situations where we have to repeat ourselves. At times, especially in my situation, we were in severe crisis, and focusing on our support that we needed to get from our son, the barriers that we faced previously, and the system not routinely asking, staff not asking, and giving us that reasonable adjustments. 2 years ago, nearly to the day, I experienced firsthand what can happen when these things aren't in place. My son and I were involved in a significant incident during our hospital admission, which caused profound impact on both of us. It was traumatic. It left us felt unheard and unsupported. But looking back, many of those risks could have been recognised early, if we had something like the Disability Identifier. I've been heavily involved with the Disability Liaison Officer at the Royal Children's Hospital and Code Grey team. Because I've completed that Disability Identifier, we now have had early discussions, proactive planning. We've got a Code Grey plan. My son cannot walk in the door of any hospital. We've had to have police involved. With having this identifier, we have everyone of all of his care team having meetings, understanding what needs are before we even get there. We reduce risk early, we put in strategies. What used to be a traumatic event, even heading towards the hospital, is not of it. My son can attend the hospital calm, well planned. They're so respectful of what we need. And the positive experiences moving forward, we've actually been able to attend 4 or 5 times unplanned without one incident, where before we had, an hour and a half of code grey and incidences. The other issue is how exhausted I was before these identifiers came out, of how I had to navigate different systems. It's not just the hospitals, it's NDIS, it's school, it's Centrelink, it's all the community services. By having this disability identifier over all health and community services provides that information that I'm not repeating. It's coordinated and it gives us reasonable adjustments, and it prevents me from carers burnout. Gives me the energy and capacity to focus on my son's needs instead of trying to be that voice. So the identifier has been significantly life-changing for our family, and especially for the hospital as well. The staff are trained and supported with my son's needs.
What a phenomenal outcome for you. It's everyone surrounding the patient as well, not just the patient.
It's not just Archie or myself, it's the clinicians, the health services, but that would not have happened without me being linked into the Disability Liaison and Code Grey and having the questionnaire completed, because now he's got a behaviour of concern charts. It's all on his EMR. And then one step further would be great if it could be, merged over multiple services, because that's the biggest burnout, is that you've got to advocate and repeat yourself multiple times. But having this already at the children's has reduced that significant barrier.
That's great. Thank you for sharing your story, Amy. Kath, I'm going to move on to you. You're the Chief Allied Health Information Officer at Parkville. One of the strengths of this project is that it wasn't simply about creating a form or a screening tool. It was about embedding the disability identification into routine clinical workflows. Can you tell us a little bit about what helped the implementation to be so successful from a digital perspective, and and how much training was involved for staff?
Yes, thank you, Anna. I was really excited when the disability liaison officers first came to say, we need to do something about this. So I sort of work as a liaison between the clinicians and then our EMR team, who are going to eventually do the build that we need. I think spending a bit of time looking into what was currently available, knowing that there wasn't anything available, that sort of specialty component sat with our consumers and our clinicians and our specialists. And so my role is really when we get to the how. So they developed the what was required. And then we really thought closely about, for me, the things that we really thought about is this is a patient's voice. So it's not a clinician's voice. So we have to be thinking about how are we going to phrase the questions, where is it going to be available so that we can have it available for our patients. At Parkville, we're lucky we have a patient portal, which is attached to it's part of our electronic medical record in essence. So some of the things that we did was made this questionnaire available to anyone who has access to our patient portal. You don't have to tick a box to have it. And what we're finding is people, there's a questionnaire section. And often when people first use the portal, they're just having, oh, this is interesting, have a bit of a look through. And then they're coming across the questionnaire. And we have 70, 82% of people who are filling it in just saying, no, I don't have a disability. But great. That's really important information for us. And we're having about 50% completion through our patient portal. With our cohort that have a disability, it's much higher, but overall, it's a really great way for us to be able to capture patients' information and from their perspective. The other thing we thought was really closely about how can we use the tools to help clinicians once we've got this information. So Joe showed there's an icon that sits on the very visible for our for our clinicians, and you just have to hover over it to see the information you need. So we wanted it to be easy to access, and initially it was a bit tricky with people filling it in, but we've done some updates. So if the symbol's there, it allows you actually to go in and update it and complete it if you're a clinician talking to a patient. The other thing is we've used some other things to drive. So even if the patient hasn't completed the questionnaire, or maybe they don't have the portal, if we have an NDIS number in the system, that will automatically bring up the disability icon as well. And then it's flagging people, oh, maybe we actually need to ask these questions. So we used as much as we could. And then the other thing we did was made sure we had reports so that we can start looking at this information, because we wanted to understand what is the uptake. And one of the things we really look at from an informatics perspective, is what was the acceptability? So were people happy using it? And partly what we do after we did the evaluation, we could take that feedback and say, right, this part wasn't exactly right, and then lead optimizations from that perspective so that we felt like everyone was comfortable using that and we had done the best possible. From a very basic education perspective, we have tip sheets for clinicians to show you how you use the tool from an EMR perspective, but I think Lou might touch on it, but there was a lot of work also which was more around from a staff member's perspective.
Great, thanks, Kath. And on the form, when people are filling it in, are there other identifiers as well? Do you have sort of Aboriginal Torres Strait Island identifiers or gender identifiers?
Great. So there were 3 big projects we did at Parkville. The first one was actually what we called our sexual orientation, gender identity. So there are some of those actually available in the portal. Not all of the questions are available, but some of them are. So that I can go in and update my gender, and we're really strong around what was my sex reported at birth versus what would I. And we also have something which has actually been really helpful for lots of communities, is a place where I personally put in what my preferred name is.
Yeah.
So we're using that with our Aboriginal and Torres Strait Islander groups, because I might use auntie or uncle, and I want that to be used. So they can add that. People from sexual orientation, gender identity group, from that project. That's where we brought in this question, but it allows them then to say, this is the name. And then when I'm looking at the person's file, it will have, for example, if I had a different name, or my name's Catherine, but I like to be called Kath, it actually in my medical record says Catherine, and then then it has Kath Feely. So it's really clear that this person would like to be called something different.
Yeah.
And then the gender identity questions are there, and good segue. We have just around 12 months ago, we've done a similar process with our Aboriginal and Torres Strait Islander Aboriginal teams across Parkville, similar co-design process, and we've sort of we learned from our sexual orientation, gender identity work, then we learned more from our disability work. So now we're looking at this, and we've just launched, well, it's been there about a year, about to start looking at that data, but we have some cultural questions that patients are now able to fill in. The only difference is you have to identify as Aboriginal or Torres Strait Islander before we drop those questions into the portal. But clinicians can ask the questions anytime.
Yeah, that's so good. So that's seemingly small things that make such a difference in people's experience. Thanks, Kath. Louise, you're at Royal Melbourne Hospital. Introducing new workflows a part of the story, but sustaining it really depends on clinician understanding. What have you learnt about supporting the implementation, and what have been some of the most effective strategies?
And I think trying to implement anything into a busy tertiary hospital is fraught with danger, and particularly something to change workflow. There's three main things that we learnt. One was that you definitely need organisational support behind it. That's right across the organisation. That what you're implementing needs to be user-friendly and valuable, so value add to the daily work of the people who are in the trenches, so to speak. And the other thing that we learned is that we need to have continuous education and training because of the changeover of work people, the staff within the hospital. So they're the main three key learning things that we learned when we were implementing it. I guess you're talking about strategies that we used. Obviously, the very first thing we did was liaise with our managers, allied health, nursing and medical, and also our executive team to introduce a disability identifier tool. And we linked it to our hospital focus of consumer engagement and health equity, and that the tool sat very nicely around that. And another strategy that we implemented was to demonstrate to the workforce and to also our patient population of the win-win value of the tool. And I guess Bradley and Amy have really spoken about that as, that how it's changed their experience of health. And I can say from a clinician's perspective, the clinicians are eternally grateful of being provided with the tools and the knowledge to make those accommodations for the people that they're caring for. Pre-implementation, before we even implemented the tool, we had a really major service-wide education and training blitz, and we tailored education and training to each specific area, from ED to the community services. We provided really practical step-by-step guides to implementing or to completing the disability identifier, but also implementing it within their particular service, again making it specific to each area, because it's very differently used in different areas. And we did training in groups, so we did it one-on-one, whatever that particular area of the hospital needed. We also embarked on a big awareness program for our population with a disability to complete the disability identifier. We had lots of brochures around in ED, on the wards, outpatients areas, all that sort of stuff. We also had a lot of information on our website, and we also contacted major disability organisations like Scope and Amaze and Vision Australia and so forth, and informed them of the disability identifier should any of their cohort come to the Royal Melbourne or the precinct area. And again, provided, that step-by-step, really practical information for people with disability or their family or their carers to fill in the disability identifier. So we had posters all throughout the hospital, and we really took advantage of any awareness days that were in a calendar. It might be the International Day of People with a Disability, or it might be a Vision Australia Day, or whatever it might be. We took real advantage of those awareness days to promote the disability identifier to our staff and patients. And we did this, usually with tables in the foyer or an art show or something like that. And another strategy that worked really well was the sharing of the win-win stories with the Royal Melbourne cohort, both internally and externally, in our media and communications outlets. And as Amy said, everyone loves a great ending story, and when it's a win-win both ways, from not only the person and their family receiving the care, but also those providing the care. But I guess, the biggest thing is keeping that awareness in the forefront of our caring population, whether it be as I said, the people receiving the care or the people providing the care. So we have regular dates in education programs of teams, departments, wards, right across the hospital, and the education programs are ongoing. They usually last about and we tailor it again in 10 to 20 minutes, depending on what the particular area needs. And it's just a refresher to keep it in the forefront. So they're probably the main things, is just Amy, the education and following up and taking any opportunity you possibly can to promote it.
Thanks, Louise. And have you had to do any sort of capacity or training with clinicians in terms of how they actually deliver the reasonable adjustments in what the skills they need to actually deliver certain things?
It's so, because it is the voice of the consumer or the patient, Amy, it's so individual and so particular. So sometimes we might be there with their main their main communication partner and say, oh, this is the best way, and we'll work with them for the first half hour or so of that person's inpatient stay, and we'll learn off the people who know the best about them. Or it might be because most accommodations aren't massive. Some might be just allow a bit more time to process information. Speak on the right side of the person because they're deaf in their left ear, and they're not going to bring their hearing aids in because you've lost 2 sets of them already and it's cost $6,000. So, all those types of things. So sometimes it's those minimal accommodations, and we've got a highly skilled workforce. Like they have lots of tools anyway. I guess it's giving them permission to use those tools in an environment that's quite rigid and needs to be for safety, but giving them the permission to use their common sense and the skills that they all have.
Yeah, sure. Again, just small things that make such an enormous difference.
Really small things. Yeah. And as Amy was talking about, with outpatient appointments, making sure that if someone doesn't tolerate a really busy, loud environment, then coming to an outpatient appointment and having to allow 3 hours to wait is just it won't work. So, making sure that there is a time that person can be seen, that the clinician who is going to see them, whether it be a nurse, a allied health or a medical, are there at that time, and it's coordinated so they can park in the car park, get escorted to the particular clinic, be seen by that group of people that they need to see, and have it clustered care, and then leave the clinic makes a massive difference.
Yeah, thanks, Louise. Kristen, Austin Health has taken a slightly different implementation pathway by embedding the disability identifier into their Cerner software and using a mandatory inpatient nursing assessment. Can you tell us what you've learned about making the disability identification part of routine practice?
Great, thanks, Anna. I think one of the key lessons which Jo spoke to initially is what we've learned about that disability identification is most successful when it's embedded in an existing admission workflow rather than being introduced as a separate process. Our workforce is busy, and so by embedding it in an existing workflow really assists with the completion rates. So at Austin, we incorporated the disability identifier as a mandatory question in our inpatient nursing admission assessments. Our nursing workforce complete the question initially, but any member of staff can update the information or change the information as per patient requests. And this has really helped to normalise the conversation around disability and making sure that that's part of our routine care or routine practice. We've also found that, as Lou was talking a little bit too, that staff education has been really critical and really helping clinicians see that the disability identifier is not about or is not primarily about data collection, but is more about ensuring that patients receive the adjustments, the support, and the communication strategies they need for safe and equitable care. I think one of our other really important lessons has been the need for the clear pathways following identification. So staff are then more engaged to see if they see how the information is used. And so whether that's prompting reasonable adjustments, informing care planning, as we've heard about both from Bradley and Amy, or facilitating that referral to the disability liaison officer. But to give you an idea and just seeing some of the questions in the chat, at Austin, we see about 330 to 530 or somewhere between that patients per month that identify, or inpatients per month that identify as having a disability. But the DLO program only sees about 30 to 50 referrals from those people that have identified. So otherwise, their adjustments are being supported by the treating teams on the ward, be that doctors, nursing, allied health, etc. So I think overall, our experience has shown that making the disability identifier routine, but meaningful and actionable is really about what's driven the completion rates, and I think has seen those better patient outcomes.
Fantastic. Thanks, Kristen. Jo, a couple of questions for you, if I can. Does the information follow a patient between the different hospitals, or is it just relevant to the hospital they've been admitted to?
Very good question. At the moment, we're fortunate within the Parkville precinct that we're all using the same shared EMR system. So we do have the benefit of that information following patients across the different Parkville hospitals, and that's particularly helpful for our young people that are transitioning into an adult service. It's often sort of locally sort of moving across to Royal Melbourne Hospital, or if there's other care that's happening at the Women's or Peter MacCallum Cancer Centre. We're really seeing the benefits in that, and Amy touched on it a little bit as well, that it's not just within the health service, that it's challenging to navigate communication and repeating information and making sure that that health services are prepared and aware of individualised needs. It's across health services. At the moment in Victoria, we are all on different systems across the state. So at the moment we don't have that integration across health services, but it's definitely something that would be the ideal goal down the track. And there are things that that we've been looking at, I guess, in a broader sense around interoperability and being able to work across systems. But certainly in jurisdictions where there's a shared EMR platform, there's a great opportunity there to be able to do something like this across health services.
Great, thank you, Jo. And look, there's millions of questions. I think we could go on for another hour asking you all these questions. But I do just want to go back to our consumers. Bradley, I was wondering if there was one message that you wanted other health services to hear today. What would that about this Disability Identifier Project? What would that be?
Go for it. Basically, I would suggest working with go with the co-design process. The co-design process at the Royal Melbourne worked really, really well. I was involved in the question co-design part of things, and that it makes us feel like a person with a disability, makes us feel that we're part of the service. We're not, oh yeah, we'll do this for them, but yeah, we're actually feeling part of the service. It was really great to be involved, and for the hospital to sort of come along and design something like this was just a fantastic initiative. Like Amy sort of said, it helps avoid a lot of problems if we can possibly can, and make us move through the hospital system smoothly as possible. And that's just a fantastic thing. And what Kath and everybody has done with it is just absolutely fantastic.
Excellent. I had a question on the co-design actually, and Jo, you might be able to answer this. Did you co-design it uniquely for each hospital, or did you co-design it at one and then replicated that across the others?
No, we did it collectively. So
Okay.
it was a time-consuming process. It was, it's challenging. It's always challenging to bring together many stakeholders and diverse stakeholders as well. We've got very different patient groups, I think it's good to be aware of the investment that takes, and what it means to bring together a large group of stakeholders. But it just wouldn't be what it is without having done that, and having that shared ownership and involvement right from the outset. It was absolutely worth taking the time that it did to do that properly.
Yeah, that's great. And Amy, Bradley said his one message is just go for it. What would your message be to health services looking to do something similar?
Like with all the other speakers, it's about being measurable, and you're collecting it, but what are you going to do with it? So I'm actually a healthcare professional as well. I've got multiple roles and hats, and I specialise in primary care previously. So it needs to be it needs to be across all health that it needs to be introduced. And it needs ways of integration between all of the services, and the electronic records definitely do help, but it can't be utilised and put in the supports by the clinicians, because they're usually looking at why we're presenting for medical, but our psychosocial and all our other needs is we need more disability liaison officers embedded in all health services, or nurse navigators to help with that, so that they can refer to somewhere to help. Like you said, you've had how many people identify? Of that percentage, I'd love to know how many people know about the Disability Liaison service, because I think if they knew what they were and how they can help, that numbers would significantly increase.
Thanks, Amy. Look, we've reached the hour, which is a shame, because, like I said, we could go on. There's so many more questions that we have, but I have to bring the session to a close. I'd like to thank our panelists for joining us today and sharing this fantastic initiative, in particular, Bradley and Amy for being kind enough to share their own stories with us. And I'd like to thank you all for joining us today. Look out for our next newsletter later this month. And I look forward to seeing you all at our next Person-Centred Care in Practice webinar. Thank you very much.